Hello and welcome to Convent House Pathology for the first in the series of introductory lectures on pathology, which for UCL students form part of the movement and musculoskeletal biology module in Year 2. For this reason, the specific examples of pathology in the lectures are drawn from the field of musculoskeletal pathology, but the lectures themselves can be appreciated by anyone who desires a general overview of pathology by way of an introduction to that subject at university level. Since I was a medical student in the 1980s, the proportion of the curriculum occupied by pathology has steadily diminished. The subject now no longer has its own examination and is becoming increasingly marginalized, something that will no doubt bring joy to the hearts of those many people who dislike the subject and find it rather tedious. Why, therefore, study pathology? I don't have any vested interest in encouraging people to do so. I don't get paid for teaching pathology or for making lecture content about it. I do get paid for doing pathology, and I have made a living doing it for the past 25 years. I don't have any particular reason to encourage others to plough the same furrow, except that there will eventually come a time when I'm furloughed permanently and someone will have to come after. Many people think they know exactly what pathologists do, and they think it looks like this. They think that we spend all day investigating unexplained deaths in mortuaries surrounded by beautiful women. And in my case, that is exactly what I do, because I don't work for the National Health Service. However, the majority of pathologists who do spend most of their time looking at surgical resection specimens and rendering a diagnosis, advising on prognosis and treatment. Even within the medical profession, the work of the pathologist is not always appreciated. To quote Dr. Colin Douglas, writing in the British Medical Journal in 2005, there are many areas within medicine where a capacity for the solitary pursuit of ever more specialist knowledge through a relentless accumulation of minutiae that might bore others witless may, together with the sometimes liberating influence of having little or no value for or even awareness of the feelings of others, lead to a truly brilliant career. If that doesn't sound too bad, unfortunately, goes on Dr. Douglas, that is exceptional. Dr. A is more likely to be found as an odd, insensitive clinician, or perhaps less unhappily, in an impenetrable laboratory, hunched over a friendly microscope or an unthreatening computer, content in his fashion, and perhaps even doing some good. Thank you, Dr. Douglas. Only kidding. Pathology is the basis of Western medicine. That statement sounds exceedingly pretentious, but it is merely a truism. There are all kinds of medical paradigms through which the treatment of disease is approached. Western medicine is one of them, and it's what I was taught, and it's what I have taught in medical schools, and it is based on a certain understanding of the origin and causation of disease. And that is based on viewing the body as being composed of cells, tissues, and organs, an insight that we have from the 19th century French pathologist Xavier Bichat, who nowadays is almost forgotten, but in his time was considered to have produced work as significant as that of Darwin, in that it revolutionized the way in which disease was seen. Wherever in the body disease occurred, if you examined the diseased tissues closely, you saw similar patterns and could therefore make generalizations about the nature of the condition that afflicted your patient. If we think for a moment about other approaches to disease, and we have here humoral medicine as practiced in the Middle Ages or traditional Chinese medicine, what they have in common with Western medicine is that their practitioners take a history, examine the patient, prescribe a treatment, and monitor the patient's progress. That is common to all medical paradigms. What sets us apart is that we have an appreciation of the etiology and pathogenesis of disease that is based on the study of cellular pathology. So what do these words mean? The etiology of a disease is its cause, and without getting too hung up on philosophical notions of what the causation of disease actually is, the underlying thing that makes you ill. So in the case of tuberculosis, the Bacillus mycobacterium tuberculosis is the thing that's causing the illness. And the so-called diagnostic sieve has the acronym CAT in bed. I've just recorded this 3 times trying to get it right, so it's not helping me remember it. Congenital, acquired, traumatic, infective, neoplastic, blood, endocrine, and degenerative. Yes, I've finally got it right. The pathogenesis is how the cause produces the disease. And this is of interest because if you know how the cause produces the disease, you can try to interfere in the sequence of events. So if you're trying to treat lung cancer, you can either stop people smoking cigarettes to begin with, or once they have smoked cigarettes, you can try to interfere with the neoplastic process as the tumour develops and spreads. You can try to hinder this and destroy the tumour. The joint is red and hot, the red hot joint of the title, because it's inflamed, and redness and heat are 2 of the signs of inflammation, which we recognise wherever we find it in the body. And here we see some inflamed finger joints showing this redness and swelling. What are the other characteristics? Well, they might be painful, they might have limited movement, or they might be warm to the touch. These together make up the 5 cardinal signs of inflammation, which, as they were first proposed by Galen, are traditionally rendered in Latin as rubor, calor, tumor, dolor, and functio laesa. Let's go through these one at a time. Rubor, redness, is due to dilatation of the small blood vessels. Blood being red, the tissues themselves that are inflamed will appear red. And this has a functional advantage because it will deliver antibody to the infected area, and it will also deliver antibiotics, although of course it wasn't designed to do that. The antibiotics were designed to take advantage of the increased blood flow. The heat or calor is also due to blood flow because blood is warmer than the surrounding tissues. And on top of that, there is an exothermic chemical reaction that's caused by the inflammatory mediator molecules released at the site of the inflammation. The tumour is swelling. If something's inflamed, it's turgid and swollen, and you can probably leave a dent in it when you poke it with your umbrella due to there being an accumulation of fluid in the extracellular space. Pain is due to the inflammatory mediators stimulating pain receptors in the skin, and pain is of course nature's way of telling you to stop doing whatever you've been doing now. And then the pain and the swelling causes loss of function. All of these are classical except for the final one, functio laesa, which was added by Rudolf Virchow, a great German pathologist active at the end of the 19th century. These acute inflammatory changes are increase in the diameter of the capillaries, increased hydrostatic pressure in the capillaries, which will force fluid out of them and will drive proteins into the extracellular space, increased colloid osmotic pressure in the tissues due to the proteins accumulating there, which will draw out more fluid from the circulatory system, and this is the inflammatory exudate. If you have a shallow ulcer, there will first of all appear a straw-coloured fluid as the ulcer weeps, and then this will solidify into a yellowish crust that it's difficult to resist picking at, and the crust is made of solidified proteins. Here in the diagram of the circulatory system, we see the capillary bed. Normally, of course, the amount of fluid going in should exactly match the amount coming out. In inflammation, this is not the case. The incoming arteriole dilates and the capillaries themselves become leaky. The fenestrations in their walls open up and fluid will accumulate in the tissues. Even though the venules also dilate and blood flow as a whole is increased, there'll still be some fluid that's coming out of the circulatory system and accumulating in the extracellular spaces of the tissues. What causes the increased vascular permeability? There are many chemical mediators, particularly histamine, bradykinin, nitrous oxide, elements of the complement pathway, leukotriene B4, and platelet activating factor. There is also, in acute injury, direct trauma. If you hit something hard enough and keep beating it up and macerating it, you will simply destroy the walls of the vessels and they will lose their structural integrity that way and therefore will become leaky. On longer term, you'll find that there's endothelial cell injury caused, for example, by bacterial toxins that also compromise the integrity of the circulatory system. So as long as the inflammation continues, the blood vessels will have a tendency to be leaky. Here we have a little identity parade of inflammatory cells. A monocyte is a circulating macrophage. A lymphocyte is those little cells that don't have any visible cytoplasm and just have a little dark nucleus. Then you have the polymorphs, which are three in type: the neutrophil polymorph, the eosinophil polymorph, and the basophil. The commonest of those in inflammation is the neutrophil, also sometimes called the polymorphonuclear leukocyte. Then you have the macrophage, which is a monocyte that's in the tissues. A red blood cell is just there for comparison, and the final element of the hemopoietic system are platelets, which of course play a role in clotting of blood. Here we have a family tree showing how they're all related. In acute inflammation, there's increased production of white blood cells, and with this increased production, blasts, immature white cells, will enter the circulation. This is known as left shift because when you draw a picture of the cells maturing in the West, you obviously draw it maturing from left to right because that's the way we look at things. So the shift is towards the left of the picture, with immature cells beginning to appear in the circulation. And when you see this, it's an indication that acute inflammation is in progress. Here we see the capillary itself with the blood cells within. The inflammatory cells are going to make their way from within the capillary to without, and they do this in stages. As the speed of the blood flow diminishes, they will naturally be drawn to the outside of the capillary, which is known as margination. And when they get there, antigens on the surface of the cell react with receptors on the endothelial lining of the capillary cells, and this activates the inflammatory cells. In this case, it's a neutrophil. It then adheres to the wall of the capillary, it transmigrates, and it makes its way out through the gaps between the capillary endothelial cells to a life of freedom in the extracellular space. This diagram just makes the point that it isn't a random process. The white blood cell is looking for particular cell surface antigens, and these are exposed in particular during inflammation, causing the white cells to adhere. A neutrophil polymorph is an acute inflammatory cell. When speaking of inflammation, we don't use acute and chronic in the normal medical sense of acute meaning having lasted less than 24 hours and chronic meaning greater than 24 hours. Acute inflammation is inflammation involving neutrophil polymorphs. And if the neutrophils are present, it's acute inflammation regardless of the time period for which the inflammation has been going on. What do the neutrophils do? Well, they stick to microorganisms, they phagocytose them, and they kill them. It's as simple as that. The role of the macrophage is something similar, only as their name suggests, they're somewhat bigger eaters, and they will also gobble up effete neutrophils and all other kinds of bits of rubbish, and then in the little diagram they obligingly melt away into nothingness, presumably remarking, "Don't thank me, it's all part of my job." Macrophages contain lysosomes, lysosomes contain enzymes, enzymes degrade proteins, and these enzymes are responsible for the destruction of ingested microorganisms and effete neutrophil polymorphs. Lysosomes were discovered in the 1960s by a Frenchman called Christian de Duve, and he had a typical Gallic melancholy, which is fully understandable in that unhappy race, and he decided that lysosomes were in fact suicide bags, and that when the cell had become tired of the futility of existence and had seen all the trendy, arty French movies it could possibly tolerate, would simply detonate its lysosomes and melt away. Well, there's some truth in it, because the enzymes from burst lysosomes end up all over the place, and they do damage to innocent bystander tissues. Inflammation isn't as specific as it might be, and you will get damage to normal surrounding structures. There's also the issue of where the effete inflammatory cells go. In some cases, they will drain into the lymphatics, and you'll then get enlargement of the regional lymph nodes because they're stuffed with inflammatory cells from the inflamed area, particularly if it's in the periphery. In other cases, they will form a collection, and a collection of dead neutrophils is called pus, which will remain there until it's released surgically, or it will form an abscess. The formation of an abscess will, in the end, impede healing, and this is another of the examples of when inflammation has negative effects as well as positive. When a tissue becomes acutely inflamed, certain inflammatory mediators, certain chemicals are released at the site. Amines, components of the complement cascade, eicosanoids such as arachidonic acid, the clotting cascade and the kinin cascade are also activated. This slide and the following slide are included not because it will be advantageous for anyone to memorize the pathway, but simply to show how everything is connected to everything else. There are checks and balances in the system, and in some cases, two separate cascades are activated that have balancing effects. The increased blood flow and fluid in the tissues will dilute toxins. This obviously has an evolutionary advantage if you're bitten on the toe by a poisonous serpent, for example. in that it will help dilute the venom and delay its arrival in the heart, where it might do some real damage. Incidentally, a study of serpent bites indicates that the best way of avoiding them is to wear shoes, no, seriously, and don't go out to fetch water or to go out to pass water after sunset. Activating the cascades causes clotting, which obviously achieves hemostasis. Increased blood flow means increased oxygen, means increased abilities of the tissues to repair because they will consume energy in doing so, and the activation of complement will initiate the immune response. On the negative side, there's damage to the normal tissues, the innocent bystanders, digested by enzymes, squashed by abscesses, or ischemic because the vessels that supply them have been damaged. There's the possibility of swelling in critical sites. Intercerebral inflammation in particular can lead to fatal raised intracranial pressure. Swelling of the epiglottis can lead to asphyxia. Even though these are benign in the sense of non-malignant processes, they can be rapidly fatal. Then there are hypersensitivity reactions in which the inflammatory response is inappropriate. What are the possible outcomes? Well, it can all end happily ever after. It can completely resolve. I'm sorry to say that isn't common. And resolution means what it says, exactly back to normal, just as it always was. It's not the same as healing. Healing leaves a scar. Resolution is exactly back to normal. So if you've had a zit on the end of your nose and it's not there now, it is resolved. It's gone away completely. If you've had chicken pox, as I have, and have chicken pox scars, they've healed. They've got better, but there's still a scar where the inflammation was. The bad outcome is accumulation of pus, particularly in a joint, which may lead to long-term problems with erosion of the joint. If the inflammation extends to bone, this will cause osteomyelitis, which is extremely difficult to deal with, as it's difficult to get antibiotics into the bone cavity. No pathology museum would be complete without a specimen of osteomyelitis. It used to be very common, and bones are very durable, so these specimens have accumulated in museums. If you do have a chance to visit a pathology museum, please do so, because they are amazingly educational places, and it's much easier to learn pathology by looking at actual specimens in pots than it is by looking at pictures of them. The systemic effects of inflammation include having a high temperature, which is due to exothermic reactions of inflammatory mediators, feeling ill, malaise. It always seems a strange kind of symptom because you'd hardly go to the doctor if you felt well, but we can appreciate that in some circumstances you just feel as though something strange is happening within, and this may be because inflammatory mediators are circulating and there's some internal inflammation, such as in the abdominal cavity, that can't be appreciated on examination. Lymphoreticular hyperplasia, so the spleen becomes enlarged and so do the lymph nodes. You may pick this up if you examine your patient, and there are non-specific markers of inflammation. In my day it was the raised ESR, the erythrocyte sedimentation rate, raised white cell counts, and nowadays raised C-reactive proteins, all of them vague indications that something inflammatory is going on somewhere, that have very little diagnostic value. Once inflammation becomes chronic, it will not resolve, it will only repair, and so will leave a scar. Another possible outcome is regeneration. Unfortunately, humans have largely lost the knack, although we can regenerate liver. Some creatures, such as amphibians, can regenerate limbs and tails. At one time, it was thought that reactivating this lost potential might have great therapeutic benefit, and for some time Sir Peter Medawar worked on this, but sadly little progress has so far been made. In part 2 of the first lecture, we consider some specific examples of inflammation in relation to the musculoskeletal system, infection of joints, crystal deposition, acute flares of chronic arthritis, and the effects of trauma. The Greeks, of course, had a word for it: the 5 cardinal signs of inflammation: rubor, tumor, calor, dolor, and functiolacea. Thank you.